did this last time. Okay, it's recording now, it looks like. Sorry. I don't know what happens, Renee, if I should start your recording before or after, but anyway, now it's working. So good evening, everyone. I'm Deneen Feist, and I'm the Director for Family Voices of North Dakota, and we'll walk through a little bit about what Family Voices is and what we do. Family Voices National is really the mothership of all of us. There is a Family Voices chapter in every state and territory in the country. Um, and so we are a chapter of that. And we are also a chapter of the National Parent to Parent USA. A little bit of background, and I think it might come up in another slide, and if it does, we'll skip it. But years ago, my son was diagnosed with a bilateral hearing loss that was quite significant, bordering on not, it wasn't like complete deafness, but it was it had, his hearing dipped in the very between profound and the step right above that. So at that time, there was no newborn hearing screenings, and he was probably about, he was born with the cord wrapped around his neck, and so I don't know if it was that or if there was something genetic. We still don't know that, but he was getting close to 2.5 years old. He had started talking, but somewhere in between there, he had gotten several pretty significant hearing infections, and his temp spiked a couple times to 104, 105. And so who knows which led to his hearing impairment, but nonetheless, he did. And I kept telling the my private practice physician that there was something wrong. He wasn't talking. He started to talk, and then it just kind of went away. Anyway, I'm also a nurse, so he kept saying that I was an overreactive mom and blah, 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 that I knew too much. And so another probably 2, 3 months had gone by, and he still hadn't started doing a lot of chattering yet. There was a lot of screaming that had gone on out of pure frustration, I think. At times there were, anyway, we had taken him into an ear, nose, and throat and an audiologist in Fargo at the time. And it was there that he was diagnosed with his hearing impairment. So we got him aided, and we switched to an audiologist that was in Jamestown at the time, which ended up being quite a blessing. And the reason we switched is because they wanted us to come back to Fargo for therapy, start speech therapy 4 days a week. Well, I live in Edgeley, and that's a 2-hour drive every day. Well, one way. And so that's why we switched to someone in Jamestown. And as it turned out, the blessing is that she also had a son that had a significant hearing delay, and she really became a really great mentor for me. We also had a young boy in our school that that also had a hearing difference. So we had a teacher of the deaf in our school, and that also was really a hidden blessing for us as well. So that's kind of how I started to get involved. I was part of the Early Intervention Interagency Coordinating Council at the time. We were part of a family involvement subcommittee. And I got on that because our special ed teacher at the time, I said, there's got to be a better way for families to meet each other, to just to be able to share information and learn from one another, identify what systems we might be needing. So she led me to that interagency coordinating council, which again, was the family involvement subcommittee. That subcommittee sent us, there were several of us that went to what was then called the International Parent to Parent Conference, and it was in Albuquerque, New Mexico. And it was there that I met 2 of the 3 leaders of Family Voices National, and they were looking to expand to every state in the nation. So I'm thinking that this was like 1980, let me figure this out in my head. Was like about 1984. So it tells you how long that I've been doing this. So anyway, in those early days, I was like a sponge for information. I just literally a sponge. So they asked if I would be willing to look at starting a chapter of Family Voices in the near future. And in those days, I always agreed to everything too. So that was part of my maybe healing, I'm not sure, because there was really quite a few bumps in along the way. Um, the audiologist that we had was initially not very family friendly, I'll just say it that way. Um, every time we would look to apply for services, it felt like a door was shut. There was just a lot of bumps. So that family involvement subcommittee really became quite important, not just for the camaraderie, but for everything that I learned from that. So again, we were in New Mexico and at this international parent to parent. And so I did start that Family Voices chapter, and they handed me a disc with 50 names on it. Well, the problem is I didn't have a computer. So I went to our local Lions and JC chapter and asked for some funds to get Family Voices off the ground. And then they gave me the funds for a computer. So at least if nothing else, I could start with a newsletter. And then we went to anything and everything that we possibly could, because I was still working full-time as a nurse at the time. And anyway, Family Voices of North Dakota was born um, out of that experience. So my son is now 33, and I'll just tell you a little bit about him. I'm just really impressed with and very proud of him. He focused a lot in school on sports because he was excellent at sports. And then he went on to Valley City State to play football there. And then he transferred over to the University of Mary, and he did play football there, but he got his master's degree in behavioral counseling. And and I shouldn't probably put it this way, but it was always so amazing to me for a kid with his level of hearing and how much attention you have to give to counseling and listening for behavioral health type things, that was the career path that he wanted to do. Well, after he graduated from his master's, he went to Minnesota to get his work hours done and passed his tests for LPC, LPCC, all those kind of things. And now he lives in Washington State, and he lives on oh girl, it's one of the tribes in Washington State, and he's the clinical director for their behavioral health clinic. So I'm really proud as punch of him, but it took I will say it took a village. It was from everybody at the school, his own resilience. That he was one of the most resilient kids that I've ever met, and was pretty good at self-advocacy himself. So in that, maybe he might have learned a little bit from mom. I'm not sure. But anyway, I'm really proud as punch of him. But the Family Voices mission statement is really that over with the national organization, we're a grassroots network of families and friends. Oh, wow. Hang on. Sorry. I'm going to turn my camera off. Oh, funny. My my screen door flew open. I was afraid it was going to break the glass. Anyway, we're a grassroots network of families and friends of children and youth with special health care needs and disabilities that promotes partnership with families, including those of culturally, linguistic, and geographic diversity, in order to improve healthcare services and policies for children. And I guess that's what intrigued me the most about Family Voices. With my medical background, I was really between really looking at then something in health, and it just kind of met that that goal. So a little bit about children and youth with special health care needs. This definition is really from the Maternal and Child Health Bureau. So children, they describe children with special health care needs as those who have or are at increased risk for a chronic physical, developmental, behavioral, or emotional condition, and also require health and related services of a type or amount beyond that required of children generally. And that may include kids with a heart condition. It may include kids with kidney disorders, asthma, diabetes, and then the physical, developmental, and behavioral conditions. So it's not just a child that has, you know, your like typical disabilities. It's kids that have those chronic health illnesses as well, or are medically fragile. So above all, we know that all children want to live a happy, healthy childhood, and we're in rural communities, in town, cities, and then all of our kids are involved in community activities. A lot of our kids end up having a physical disability, mental or emotional disabilities, and like I said, others have chronic health illnesses. Some may have a brief but life-threatening medical problem, and others might only have an accurate diagnosis and may need treatment, medicine, or life-sustaining technology. And that's where also, Zach and children like Zach fit into that definition as well from the Maternal and Child Health Bureau. So I'm going to give you a little bit of data, not doesn't really relevant to the EHDI project, but if you're curious about where, a lot of times I will get a lot of data from the Data Resource Center for Children and Adolescent Health. They're a wonderful resource, particularly if you might be writing grants or some progress papers, but that is a great place to pull down fairly current data on children with special health care needs and children in the general population as well. And they're funded through the Maternal and Child Health Bureau as well. So children and youth with special health care needs in North Dakota, there is approximately 34,412 kids in North Dakota, which equals out to 1 in 5 families that has a child with a chronic condition or a disability. So you can see how that breaks out. So that amounts to 19.4% of our child population in North Dakota. So, and then if you look at it by federal poverty level, you can see that 28.3% of families fall within that 0 to 99% of federal poverty level. 28.1 between 100 and 199% of federal poverty level. 16.5 from 200 to 300%, 400%, and then 14.3 is 400 and above. So you can see where many of our families are maybe living with a lower income at times, and that where services are going to be really needed, so that they the income level makes a big difference with what services that they're able to apply for, because most of them are based on income. So this one is the resilience of families. So you can see that how that compared to children without special health care needs. 18% of our families demonstrate that they are quite resilient, and 27.7% don't demonstrate some resilience in having a child with a chronic health illness or a disability compared to others. And I want to point that out, because sometimes when we get calls to our office, some families are real quick and are able to advocate on their own. But there are others that we help for, a continued period of time. And either way, it's fine. But I just wanted to point that out, because not all families are the same. So another, I guess I could skip this slide, but I think it's important to know that there are a lot of adverse childhood experiences for families and our children. And for our children and youth with special health care needs, 44.1% have 2 or more adverse childhood experiences. So when we're looking and visiting with families, it may have been, they might have some PTSD from some of the hospital visits that they've been at, or, you know, there might be like extenuating circumstances as well. So I just wanted to point that out too, because families are really dealing with a lot. The other one I wanted to point out is the fact that our children with special health care needs may not always have adequate insurance, or they might be falling in some gaps. So 20.8% of our families have a current insurance that is inadequate, or they fell within a gap in the last year. And again, that goes back to about 1 in 5. And then there was 18.4% that had adequate and continuous insurance coverage, as compared to our kiddos that don't have a disability or chronic health illness. So I think that's really kind of important as well. But this one is really, and it's one of the passions that I have, is 20%, 20.7%, almost 21% do not receive care in a well-functioning system. And you know, many times I will hear from families that this just isn't working for me. And we do several trainings that we have, and I'll talk about those later, but the intent of those is to help prepare families for working within systems, how to navigate those systems, how to do care coordination when there is no one to help with that piece. So I just wanted to make sure to point that out. And then here you can see how it's broken out by age. 12.3% are of 0 to 5 years old, 21% are 6 to 11 years old, and 12 to 17 percent are 25.2% compared to kids that in the general population. So what does Family Voices do? Well, we are a health information and education center that is funded by HRSA. That happened in the Bush administration under the Deficit Reduction Act. And the only reason I have that in my brain is because we lobbied hard to make that happen. And I got a phone call at the time, Senator Conrad was in office, and I got a phone call on Christmas Eve, or was it New Year's Eve? I think it was Christmas Eve, before they had suspended for the holiday season, that the family-to-family health information centers were funded. So that made for a real great Christmas for us here, because that was something that we had worked really hard to get. So like I said, we have a coordinator in every state, and then also in the territories. A lot of the things that the national organization does is really stay on top of the public and private sector health changes that affect our children. We share expertise of families with state and national policymakers. And we also work in hospitals, public health programs. We serve on a lot of boards and task forces to make sure that we're bringing that family perspective to the table for policy decisions and discussions. So I have a lot of staff. I mean, we have 8 staff at Family Voices, and by and large, we are grant funded, and they're not letting any grass grow under their feet. They're all on task forces in their local communities and on state task forces. I'm on several federal task forces as well, just to make sure that our voice is at that table. So above all, we believe that children deserve quality health care, that families with children with special needs who work with them have an expert understanding of what does and doesn't work within healthcare systems. And right now, currently in North Dakota, there is a cross disability work going on, because in the last legislative session, the legislative body, we have gaps in our system with the waivers. So not all of the kids are going to qualify for the DD waiver. We have an autism waiver, a medically fragile waiver, and a hospice waiver for children. Well, that leaves a lot of kiddos that are falling in that gap. So what this work is doing is identifying what the needs are, And there are several families that are on this cross disability council to identify what needs to happen so that more kids can get covered and not fall within those gaps. So that's something that is on the radar for us. We have staff on that committee as well. So there are staff and there are providers that are on there. And then also, you may have seen it, you may not have seen it, but there is a paid family caregiver pilot project that is out, which if you have a child that is on a waiver, the DD waiver in particular, and haven't been able to find respite care, or you've had to give up your job because of the lack of the ability to have someone help with the care of your child, you can apply for this pilot project to get paid as a caregiver right now, and because there's such a shortage everywhere. So the other thing that Family Voices is that the health systems are built upon a set of tested principles and practices that flow from the expertise of families that really can improve health status and commitment to children. This new, sometimes one committee will end because it might be grant funded and another one begins, and that just happened not too long ago. And now I'm on a research federal committee or national committee as well to identify gaps there as well in the services and treatments for children with special health care needs. Again, families are that core of any health system, and that includes our families that have kids with special needs, because they're really the primary caregivers and educators for their children. And because of that, they should be respected and valued for the expertise and commitment to their children and to be at that table. And we also believe there needs to be universal access. In order for our kids to be healthy, it has to be able to guarantee unconditional access to quality and primary specialty care at a reasonable price, regardless of the family's health, income, employment, or pre-existing condition. And that services need to be flexible as well for families, and they absolutely should be comprehensive. So quality healthcare really means a coordinated system of comprehensive services, from prevention all the way through any education, screening, diagnosis, primary and specialty care, any of the available services, and as close to the family's home as possible. But really, the number one thing that we firmly believe is that family professional partnership is a must. Outcomes improve when families and professionals do decisions jointly, respecting the expertise and talents that each brings to the table. There used to be a workshop that we did called, it was called The Dance of Partnership, Why Do My Feet Hurt So Much? And it is all about family professional partnership. And there is no way that Zach would have been successful without that family professional partnership. So I just really want to stress that as well. A lot of times too, when we're focusing on outcomes, allowing family choice and strengthening and supporting the role of families and systems, costs can be reduced. We can reduce duplicative procedures, unnecessary paperwork. And as families, we practice cost containment every day. So it's really a good thing to partner just for that too. And as well as quality assurance, so that when we're working as partners and remembering those principles, families and health professionals really must review and provide feedback on healthcare financing and delivery, so that we're making sure that we're staying on top of the many changes that have happened. And boy, in the last 30 years, a lot of things have changed. So I told you a little bit about how we started. So I started as a state coordinator in 1995, but prior to that, I did some volunteer work. And like I said, we had a first computer with a mailing list of 15. We got incorporated in 2000. And then we finally received our 501c3 or our nonprofit status in March of 2001. So the family-to-family health information centers across the country really assist families in finding information about their child's diagnosis, connecting families to helpful resources, community programs, parent-to-parent programs, or diagnostic organizations. We help families understand, choose, and apply for the health insurance, whether it be private or public, programs for their child, and any other services that they may qualify for. So we oftentimes do a good bit of care coordination with the family. We do a lot of education with families and providers about private and public systems of care and ways to navigate them. We do a lot of provide information about resources and systems to health and other professionals who care for children with special health care needs. And we collect a whole lot of data for to assist in the policymakers as they are trying to make some policy decisions. This slide I borrowed from my friend Gina Polomoney. She was in touch with Kristen Lind, who is the author of this, but this was Kristen's, how many interactions that Kristen had with providers. So you can see that, and I wanted to show this because you can see the very many service providers that sometimes families end up interacting with. And, you know, it's a lot to keep straight and organize for everybody. So I wanted this as a good, because I think this is an excellent visual for the many systems that families are associating with. This slide I wanted to show you because I think it's important that providers don't always think the same way that families do. And I think this is a really good illustration of that. You can see there was a survey that was done to rank services from 1 to 15 or whatever, 22 it looks like, on what a physician felt the family needed when they were just receiving the news or providing the news that a family has a child with a disability or a chronic health illness. And then parents also rank that. So if you look at what the physicians thought, the physicians first thought that they might need respite care. Daycare was second, and parent support groups were third. But when you look at what parents said, information about community resources was number one. Number two was financial information or help. And number three was parent support groups. So always think about that when you're interacting with providers, because they may have a different idea of what the family needs as compared to what the family says that they need. So we all know why family support is so important, especially because it's connecting to others who have lived experience in successfully navigating the system of care for their youth. They'll get more access to informal and formal information and resources that are family and youth driven and centered and culturally responsive, and family and youth choice based upon their interpretation of that information. So I'm not going to go through a lot of that, but we also know that family support is a best practice. Research over and over and over again has identified that family support is vital and needed, that it is much different than the support given by the provider. Most services are provided according to guidelines that dictate eligibility, type of service, and access, whereas families of children and youth with special healthcare needs often provide assistance to ensure the well-being of their children and youth, such as care managers. They might have transportation services, social support, advocacy, help with medical treatments. And because family caregivers are generally the primary and sole caregivers to their children and youth, really their own mental and emotional health and well-being can impact how they provide that care. So a family that is well supported is going to be able to manage a lot of the things that happen better. So what we know is that we all want what is best for our kids. Accessing, I can't talk tonight, systems is very confusing. Families may get frustrated, and systems really don't make access for families easy. And a family's ability to advocate for their child's best interests will fluctuate depending upon the circumstances that's happening within that family. So if there's a death in the family, or one of the many uh, things that happen in living, um, they some families may need to take a time out and just focus on other things as well. Carlotta McCleary from the Federation of Families uses this a lot, and I love it. Really, a lot of times families are told about the slice of bread. Very rarely are they told about the entire loaf. So when a family finds out that they may have qualified for A, B, C, or D, or that there was a parent organization out there that could have helped them from the beginning, they're a little resentful that they weren't told about it sooner. So we always try to make sure that, and then reiterate to families again, because sometimes it's not always um, understood the first time, simply because there is so much to learn. We try to let families know about that loaf instead of just the slice of bread. We know that knowledge eliminates that feeling of powerlessness and dependence. Access to information needs to be understandable, free of jargon, current and complete. And parents relate, the more you know, the less scary the future looks. And that is so very true. So just another tidbit there. So some other things that we really feel like are essential to family support are recognizing that family is the constant in the child's life, to facilitate that collaboration between families and professionals. There may be a provider that the family really doesn't like, but they're afraid to say anything. And it's well within the family's rights to choose to go to another provider. We also want to remember to honor and respect family diversity in all dimensions: cultural, racial, linguistic, spiritual, and socioeconomic, and really recognize the family's strengths and the different approaches that families may need to cope. My husband, for the longest time, because Zach has an older brother that also had a diagnosis when he was growing up. Um, it was really a lot harder for my husband to cope with what was happening under our roof than I did. And maybe it was the nursing background or not, but I'll never forget the first IEP that we had. My husband came to the IEP, and pretty soon, everybody's around that table and talking, and he got up and he was in tears. He couldn't take it because, for one, they were talking about all the negative things, right? I mean, that was our first experience. They would pull in those strengths in between, but they were always talking about he may not be able to do this, or he may not be able to do that. And I think things are a little bit different now, because I think kids are so resilient that more and more providers are focusing more on those strength-based and than and child strength based instead of the negatives. Um, so anyway, he got up and walked out of the room, and he never did come back. He did go to a few meetings after that, but I also think that was the first time that he honestly admitted that, oh my God, we really need to be paying attention to this. And he is a great dad. He's always been a great dad, but I think that was the first time that it just really hit him. So those coping mechanisms are really different, I think, for every family. And it's really important to really share unbiased and honest information with family members on an ongoing basis. And I think by and large, families can tell if you're being honest and forthright and when you're not. And then we also want to encourage that family to family support and networking, whether it be through, if the child has Down syndrome, to connect them to those groups. If the child has hearing differences, to connect them to Hands and Voices, or to Family Voices, or wherever the case may be. But that is a really important aspect. And we also want to acknowledge and incorporate the developmental needs of children and family members into our practice, and designing and implementing services that are accessible culturally appropriate, respectful, and responsive. I'm not going to go a lot into family-centered care, but it is a lot that we focus on as well, because it's not just the child that is affected, it also affects the entire family in one way, shape, or form. So we're just going to skip those because I think all of us know about family-centered care. So really some things to ponder from the moment the family walks into a facility, a clinic, wherever. Realize that the communication expressed can either make or break that day's encounter, because we don't know what that family has had to deal with prior to coming into an appointment. And we have several trainings for providers to assist them as they're working with families. So some guiding principles that are really important for family support is really connecting them to those with that lived family experience. That's without saying. We also need to have coactive navigation. Families build their capacity and confidence and strength through and coaching from another parent who can share their experiences when they're traveling this journey with their child or youth diagnosis. Meaningful connections is really important because families also build capacity and confidence that way, as well as they're navigating systems through active support and coaching. And then that responsive listening is also so important as well. So we're just gonna move on. Families really need to have access to organizations that represent that lived experience. So referrals to supporting family organizations by all children and youth serving agencies and programs. We did a study a few years back about, I can't remember who we had gotten some grant funds to, but we identified a couple of scenarios. We used a couple of different names, and we contracted with a mom to make calls to, we spent time on 300 agencies across the state, and she would use the, the scenario, I'm just moving here from out of state. I have a child that has A, B, C, or D diagnosis, and where can you connect me to look for services for my child? So there was a group of us that scored the responses that she had recorded, all the responses that she had gotten, didn't identify where they were from. And then there was a group of us that scored them on a 1 to 5 Likert scale on best to worst, 1 being the worst, 5 being the best. Well, out of those 300, there was 5 agencies that scored a 5. The rest were all between 1 and 2, because most of the time when she had called an agency, they would give her a brief response and then they would say, good luck, good luck, good luck. And when it was so disheartening, I'll just say that it was something that we had suspected, because every time we would get a call from a new family, they would say, well, I called A, B, C, and D, and they didn't offer much help to me. So I just wanted you all to be aware. That study is actually on our website if anybody's interested. We also want to make sure that systems use available evidence-based parent-to-parent models and family-driven principles to connect to families. And after I had started with volunteering with Family Voices, the Family Involvement Subcommittee of the ICC, because we had gone to that International Parent-to-Parent Conference, we had gone to several actually, is when the parent-to-parent program actually took off. So that program started in North Dakota out of that Interagency Coordinating Council Family Involvement Subcommittee. And I think all of the folks that were on that subcommittee at the time really should be proud of the work that was done, because it took a little bit of time, but Parent to Parent started in North Dakota on a regular basis in 1998. So there are several family-run organizations that provide family support. Some of us have a memorandum of understanding and within the guideline principles for family support. The three statewide, well, Hands and Voices as well, we would consider that. The other, besides Family Voices, the other two would be the Federation of Families for Children's Mental Health, and then also Pathfinder Services, who helps with education and IEPs. We also want to make sure that families are engaged and have opportunities to build skills as a parent of a child or youth with special health care needs. So it really is helpful if we can get families to call us or get on our mailing list, whatever the case may be, because we do have a lot of opportunities that come up. Extended learning calls like this on other topics like Medicaid or some of the different agencies that are out there will come and do an extended learning call similar to this so that families can learn about different resources and how to navigate them. Or I think at one point we had a yoga class that was done by Zoom. I think COVID changed a lot where we used to be driving to wherever to do a workshop where you might get 3 or 4 families that would come. And I think Zoom has helped a lot because when we do our extended learning calls, a lot of times though we had several that had close to 100 on. So I think that technology has really been quite helpful. So for organizations, it's really utilization of family-run organization and their expertise to develop and training, manage programs for families that are responsive to their identified needs. Family support really is viewed as a critical and professional service to the well-being of families and children and youth with special health care needs because of an examination of the extent to which current supports are aligned, ongoing opportunities for funding and resources to ensure that family-run organizations have the capacity to sustain and support they offer. And family leaders have regular opportunities to meet with the governor, policymaker agencies, and we'll talk about some of those as well. So we do a lot of information and referral, not just for families, but we also do it for providers. We do offer that individual assistance, care coordination, and support to families of children with special health care needs. We do get a lot of medical professionals and service providers who may call and say, who do I call for this? And we're able to assist them with that. And if we're not, we'll dig for that information and contact that provider back with the information that we followed up on. Because we also know that their time is also valuable and they may not always have the time to locate that resource. Where am I at? Okay, we also have a lot of publications and assistance. We've got our website. If you go to our website, www.fvnd.org, is loaded with a lot of publications, past extended learning calls, linkages to local and state and national resources to assist families with those informational needs. There's a bit about our parent-to-parent program. I'll talk a little bit about Project Carson in a minute. That's another program that we offer under Family Voices. One thing that I will offer to Tori and to Jerusa, we do have this last spring and winter, we're on the newborn screen advisory, and we worked really closely with the newborn screen advisory to update our care notebook. And it is a great little publication for families to keep all of their records in if they need to. But it has been updated to have a fresh new look, and it's also PDF program fillable. So you can fill all the information in on your computer, carry it on a thumb drive. That way, if you're going to a service provider or specialty clinic, you have everything right in the right on your little thumb drive. So, and if there is a family that is in need of a thumb drive, we can also offer that to I can put that on a thumb drive and send it to them. So that's one thing. And then we also have a resource guide. It's called the New Beginnings Resource Guide, and that's just been recently updated for resources across the state for no matter if they're identified at 0 or if they're identified at 18, what exists across the state that might be able to assist. We have a lot of workshops available for families. One of them is a care coordination training. So like I said before, there isn't one place to get care coordination in North Dakota to help a family. So this training really is a care coordination for families to help advise them how to be their own care coordinator and work in partnership with their provider. We do have a caregiver cafe that assists families in the beginning to transitioning to adulthood. There's a new ABLE Act out there to identify how they can set one up for their child, so they can use that later to stick away some dollars or things like that, so those dollars are not held against a family. It's not Caregiver Cafe, let me think of what it's called, but we had a board member at one time who had passed away that had a couple of children with special healthcare needs, and her husband worked on the oil rigs, and we really felt from that experience that it was important to be able to provide a training for that overviews all of the services, so that if there was something that would happen, that there was a death in the family, or as they were advocating for their own child as well, that really kind of taught you how to navigate this very complicated system. And then usually from September to April, we offer evening virtual workshops for families like these. There's extended learning calls, and these are all offered to families and providers on a variety of topics to increase skills and knowledge. So our parent-to-parent program, like I said, that was started in 1998, matches new families to mentor parents for emotional and informational support. We match families based on medical issues or same diagnosis. We've had a couple of instances where there might have been an operation or surgery come up that a parent would call and say, do you have anybody that's gone through this? And then all of the parent-to-parent programs are connected through Parent-to-Parent USA, it's called. So I don't believe that there is a parent-to-parent program in every state in the country, but there is a significant amount. So either the Family Voices chapter or the parent-to-parent program may be housed, some of them might be housed in the state's PTI, or some of them might be in the ARC, but they are definitely there. So if there is ever a time when, if you need to find out where it is or how to get in connection with any of those across the country, just call and we can get that done. So like our parent-to-parent program, and also our parent-to-parent program, the families that are going to be providing support have to go through a veteran parent workshop to help them provide that emotional and informational support. That is what it was considered best practice from Parent-to-Parent USA, and we follow that model. So like I said, the parent-to-parent program is one thing, and then in partnership with Designer Genes, which is a Down syndrome network in the Bismarck area, we have a similar program called Project Carson. And Project Carson provides a similar parent-to-parent type experience, but it is for those who receive a prenatal or at-birth diagnosis. So if the baby has a prenatal diagnosis of Down syndrome, we will connect them with Roxanne Romanek from Designer Genes, or if they have a heart condition, or just whatever they are prenatally diagnosed with or given that at-birth diagnosis. So we have a separate type program to assist with that. And those we get referrals from all over. A lot of times it will be from the NICUs or the the birthing physician or pediatrician will, OBGYN will send a referral either before or when that baby's born. And then we also try to connect them to services right away so that when they are home from the hospital, that they can hit the ground running and start connecting with those service agencies that can provide that additional support. We also have and we're going to probably have it in October this year, a family leadership program. It's a weekend retreat which assists families to become leaders in North Dakota. We provide tools and resources to understand their rights, understand the process of services. There's a lot of natural mentoring that goes on that weekend. So we start on Friday at 1 and we end on Sunday at noon. So 2 solid days that they're here. They also learn about the legislative process and the process with legislators and policymakers. We have a legislator that comes or is on by Zoom. We've had that a couple times because usually about that time it's campaign season. So they may be out, ouch, darn, they're out campaigning for their position. It's a wonderful weekend. It's exhausting for me and for those that are putting it on, but everybody walks away with I think with a great experience. So I'm not sure. It's either going to be the first or second weekend in October. I'm not sure that it's going to be in Edgeley this year because I'm really concerned about our motel. Tori can kind of vouch for that. They're
Yes,
not the hotel very long, but still yeah, we're looking for a better place to host it. And the only problem with that is then I will have to haul everything to somewhere else. But if you have ideas, Tori, let me know.
I do have to say that it's a great program and very worth the time. You know, at the time when I went, I wasn't sure if I belonged just because my child has a hearing loss. But I got a lot out of it, met a lot of great people, and I would recommend it to any family with a child that has a disability.
Thanks, Tori. We enjoyed having you. So we do have staff all across North Dakota, and I'll explain to you a little bit. Joan Karpenko is in our Grand Forks office. Well, actually, we don't have an office. We all work out of our homes. So in Bismarck, that also covers the Minot area, is Vicki Peterson and Rita Starks, and they do a wonderful job. Well, all the staff do. And in Fargo, we have Jen Restemeyer, Tanya Oss Brewer, Mo Swanson. She's gotten married now, so I need to change that. And then in I covered Jamestown to Devil's Lake and up to the Canadian border, so that this middle section here. And then in Dickinson, we have Sarah Carlson, who helps us out, and in Williston is Heather Wheeler. So every region is really covered. We don't get a whole lot of calls from the Devil's Lake area, which is kind of surprising, but we do from the Minot area. And if we had the grant funds to support it, we would also have a regional coordinator up in the Minot area as well. But right now we've been able to maintain so far, and it kind of goes in streaks a little bit too. The other thing that we noticed too that that kind of happens in streaks is a rare diagnosis that we come across that none of us have ever heard before, even with my nursing hat on. And usually that happens about once every 6 to 7 months that we'll get 3 or 4 referrals of really rare diagnoses as well. So a lot of the referrals that we get, if they come from medical facilities, it'll be North Dakota facilities, or we get them from the birthing hospitals in Minneapolis. Also, we get some from Gillette Children's Hospital in Minneapolis, and what is that called? U of M. And then we also get a lot from Sanford and Sioux Falls too, because there's a lot of our North Dakota families that are going that direction. Not so many from Montana though. So how you can contact us is you can call that toll-free number anytime. and then our email, and then our website is www.fvnd.org. And, you know, take some time to go through the website, because there is a ton of information on there, and we really need to update it again. I think there are some links that are probably broken that we need to, get fixed. So that's what I have, for you guys tonight. I don't know if Melinda or anybody has any questions, Jerusha, Tori, but that's what I have for tonight.
Thank you so much, Deneen. Very nice to learn more about it. And again, another, if anyone's interested in that family leadership, reach out. Very well recommended. And I appreciate your time and you partnering with us on this.
Yeah, and as soon as we have a date and the location, we'll put out something on, if you're not on our listserv, just send me an email. We have a weekly, share the wealth. So if there's anything happening across the state for, you know, if an agency's having meetings, or if Hands and Voices is meeting in Dickinson or wherever the case may be, we'll put that into our, weekly share the wealth, and you'll have access to everything that we know that's going on in that. I usually put it out for 2 months in advance, so it will run, the same thing will run every week until the event happens, and then we take them off, but I'm also putting new things in there also every week as well. And then if you aren't a part of our snail mail newsletter, you can also get a hold of us, and let me know, and we can put you on that list as well. And that comes out two times a year, because it's gotten to be quite a large publication, and it goes out to a lot of people. There's like 8,500 on our mailing list now, which, when you think about when we started at 15, that's pretty significant change. So, I used to drive over to pick it up, to go take it to the post office to mail it, but it got to the point now that, I'm having the, folks, the publishers, just mail it from there, because it doesn't fit in my pickup anymore. So, and that was quite a bit to lift all those boxes into the post office. So it's been kind of nice, but, we had to switch things up a little bit. So anyway, if, I'm gonna stop sharing, and if anybody ever has any questions, or, just give me a call, happy to help out, or just give me an email, send an email, whatever. A lot of times, if I'm not here, our phone service is set up so that, if I'm not in my office, if I'm in somewhere for a meeting, or in DC, or wherever the case may be, it will transfer to my cell phone. And if I can't pick it up by my cell phone, it'll have a recording, and then it emails me that recording. So wherever I'm at, you can have access to me. I won't miss it, which is not always a convenient thing, especially when you're on the lake at the weekend and you want to catch fish. So anyway, well, thanks everybody. I hope that you enjoyed this tonight, and that you learned something new.
Thank you, Deneen. Appreciate it.
All right, take care.
Bye.
Very nice presentation. I always enjoy these. Thank you. You bet. Take care. Have a good week, everyone. Good night.
Good night.